Hi, my name is Carlos Gallardo, and I will talk about empagliflozin and progression of the kidney disease in type 2 diabetes. Definition: diabetes means that your blood glucose, also called blood sugar, is very high. Why type 2 diabetes? This must come the body doesn't make or use insulin well. Insulin is a hormone that helps glucose enter cells for energy. Without insulin, there is too much glucose in the blood. Over time, high blood glucose can cause serious problems with your heart, eyes, kidneys, nerves, gums, and dent.
Chronic kidney disease, CKD, is a progressive condition that leads to end-stage kidney disease and eventually death. While CKD primarily affects kidney function, it also increases a patient's risk of cardiovascular events. In fact, patients with CKD and type 2 diabetes, T2D, are 3 times more likely to die from a cardiovascular event than patients with T2D alone. Approximately 374 million people have type 2 diabetes worldwide. Up to 40% of these patients also have CKD. In patients with CKD and T2D, 3 major categories of pathophysiological drivers promote CKD progression. Hemodynamic factors like increased blood pressure, metabolic factors like elevated blood glucose, inflammatory and fibrotic factors like pro-inflammatory and pro-fibrotic proteins. But one of these is unaddressed by the current standard of care: inflammation and fibrosis. In the kidneys, the mineralocorticoid receptor, or MR, is a key trigger of inflammation and fibrosis. Under normal conditions, MR signaling regulates electrolyte and fluid balance within the kidneys. The MR may become pathologically overactivated under certain conditions, like type 2 diabetes. In patients with CKD and T2D, pathological MR activation in the kidneys is believed to be due to increased expression of the MR and its activators, which leads to the production of pro-inflammatory and pro-fibrotic proteins, inducing inflammation and fibrosis within the kidneys. Renal inflammation and fibrosis gradually cause thickening and hardening of the glomeruli and injure the kidney's tubules. Over time, inflammation and fibrosis may lead to a progressive decline in kidney function, increasing the risk of end-stage kidney disease and cardiovascular events like myocardial infarction or stroke. Because all 3 categories of drivers contribute to CKD progression, all 3 should be addressed in order to alter the course of CKD in type 2 diabetes.
Application in medicine. The use of empagliflozin has been associated with a lowering of glycated hemoglobin levels in patients with type 2 diabetes, including those with stage 2 or 3A chronic kidney disease, and with reduction in the weight and blood pressure without increases in heart rate.
Type 2 diabetes can lead to a number of complications, including kidney disease. Healthy kidneys play an important role, removing waste products from the blood. Inside the kidneys, millions of tiny blood vessels act as filters. Many substances are too big to pass through the filters, so remain in the bloodstream, while smaller substances, including some waste products, flow through the filters and become part of the urine. Kidney function helps to regulate the amount of fluids and salts in the body and control blood pressure. But with type 2 diabetes, the high levels of sugar circulating in the blood can damage the kidneys and compromise their function. Approximately 40% of patients with type 2 diabetes have established kidney disease. Patients begin to lose their kidney function, including their ability to filter out waste, medicines, and excess fluids from the body. The presence of protein in the urine can be an early sign of kidney disease. Symptoms of kidney disease may include swelling due to fluid retention, tiredness, insomnia, itchy skin, and nausea. Kidney disease progresses through different stages as the kidneys lose efficiency and waste materials build up in the body. It also increases the risk of hypoglycemia and type 2 diabetes complications, including cardiovascular disease. The last stage, kidney failure, usually requires treatment with dialysis or kidney transplantation. Many of the medications available to treat type 2 diabetes are predominantly removed from the body by the kidneys. Declining kidney function can affect that process. If the body can no longer filter medications out effectively, the risk of side effects may increase. It may also be necessary to adjust the dose of medication or change medications. As approximately 40% of people with type 2 diabetes have established kidney disease, it is important that healthcare professionals consider the kidneys and the impact they have on diabetes management.
Pros and cons. Pros. Reduce intraglomerular pressure. Improves hyperventilation in patients with type 1 diabetes. These effects may translate into improved renal outcomes. Cons. May be associated with long-term adverse renal effects. Incident or worsening nephropathy defined as progression to macroalbuminuria.
My colleagues Melanie Davis and Kamlesh Kunti and I have written a review in the journal Clinical Pharmacology, Advances and Applications on what we should know about newer therapies when treating patients with type 2 diabetes and renal impairment. An estimated 200 million people worldwide have chronic kidney disease, mainly due to diabetes, arteriosclerosis, and hypertension. Approximately 40% of patients with diabetes go on to develop chronic kidney disease. We know from major randomized control trials that intensive management of glycemic control improves incidence and progression of chronic kidney disease. It is essential, therefore, to know how to combine both new and conventional glucose-lowering therapies in patients with type 2 diabetes safely and effectively. Our review focuses on the use of both conventional and newer glucose-lowering treatment in type 2 diabetes, clearly illustrating which agents require dose adjustment or discontinuation with worsening renal impairment. Table 3 shows which conventional therapies are safe to use as chronic kidney disease progresses. In Table 4, we have summarized how the newer treatments for type 2 diabetes, specifically DPP-4 inhibitors, GLP-1 receptor agonists, and SGLT2 inhibitors, can be used safely across the chronic kidney disease spectrum. The inclusion of several new glucose-lowering treatments increases the likelihood that type 2 diabetes will be well managed in the future. This should have a positive impact on long-term incidence and progression of renal impairment. Ongoing clinical studies of large populations with diabetes and chronic kidney disease, including studies such as CANVASAR, CARMELINA, and AWARD-7, will further determine the safety and efficacy of these newer agents and confirm if they have renoprotective effects. Thank you for listening.
Hi friends, welcome to my channel for Medicos. If you or anybody in your family is a diabetic patient, then information in this video will be helpful to you. This video will contains information on new group of oral medications SGLT2 inhibitors used for treating type 2 diabetes. Before starting, If you learned something or if you find information provided in this video as helpful, please motivate us by subscribing, liking and sharing this video. So let's start. Sodium glucose cotransporter 2, SGLT2, inhibitors, which are also known as gliflozins, are a new group of oral medications used for treating type 2 diabetes. The drugs work by helping the kidneys to lower blood glucose levels. SGLT2 inhibitors have been approved for use as a treatment for diabetes since 2013. They are taken once a day with or without food. Drugs in this class are: the following drugs belong to the SGLT2 inhibitors, which are available in different trade names. 1. Empagliflozin, 2. Empagliflozin, and 3. Empagliflozin. How do SGLT2 inhibitors work? The kidneys work by filtering glucose out of the blood and then reabsorbing glucose back into the blood. The proteins that reabsorb glucose are called sodium glucose transport proteins. SGLT2 inhibitors block these proteins, which means less glucose gets reabsorbed back into the blood and gets passed out of the body via the urine. Hence, SGLT2 inhibitors work by preventing the kidneys from reabsorbing glucose back into the blood. This allows the kidneys to lower blood glucose levels, and the excess glucose in the blood is removed from the body via urine. Who are SGLT2 inhibitors suitable for? SGLT2 inhibitors may be suitable for people with type 2 diabetes that have high blood glucose levels despite being on a medication regimen such as metformin and insulin. SGLT2 inhibitors are not recommended for prescribing to people with kidney disease, as kidney disease prevents the drug from working sufficiently well. What are the benefits of SGLT2 inhibitors? SGLT2 inhibitors help to remove glucose from the blood and therefore help to lower blood glucose levels and thereby decreases risk of complications of diabetes. By removing glucose from the body, SGLT2 inhibitors can also have benefits for weight loss. Side effects of SGLT2 inhibitors: as the drugs cause more glucose to be excreted in the urine, there is a higher chance of getting genital and urinary tract infections. These side effects are more common in women than in men. Taking SGLT2 inhibitors with insulin, sulfonylureas, or glycidides may increase the risk of hypoglycemia. SGLT2 inhibitors can, in rare cases, lead to a dangerous condition called diabetic ketoacidosis. Thank you for watching this video. Please subscribe.
Used a plate in Ecuador. It is necessary to amounts to health professionals and patients about this new risk and to inform about the necessary measures to prevent their appearance, because information has been released on an increased risk of traumatic amputation, especially in those, as well as cases of diabetic ketoacidosis of unusual presentation and several cases of acute renal failure with the use of these antidiabetics.
to the American Journal of Managed Care Peer Exchange, Diabetes Therapy and Cardiovascular Outcomes, an update. My name is Dr. Dennis Scanlon, and I'm Professor of Health Policy and Administration and Director for the Center for Healthcare Policy and Research at the College of Health and Human Development at the Pennsylvania State University. Almost a decade ago, the FDA issued a guidance for evaluating cardiovascular risk in novel diabetes therapies. Although they were designed to ensure that diabetes therapies were safe, in a few cases, these large international trials have shown that diabetes therapies can offer cardiovascular benefits and reduce deaths. With us today to talk about cardiovascular outcomes trials are Dr. Zachary Bloomgarden, clinical professor in the Division of Endocrinology of the Department of Medicine of the Icahn School of Medicine at Mount Sinai in New York. Dr. Robert Gabay, Senior Vice President and Chief Medical Officer of Joslin Diabetes Center in Boston, and Associate Professor at Harvard Medical School. Dr. Silvio Inzucchi, Medical Director at Yale Diabetes Center and Professor at Yale School of Medicine. And Dr. Kenneth Snow, the Medical Director for Aetna. So thank you all for joining us, and let's begin. I wanted to start by talking about cardiovascular outcomes in diabetes and really what we know so far. So the Empareg outcome trial produced results that had not been seen before in diabetes care. A treatment for type 2 diabetes that was found to have cardioprotective benefits. And Dr. Inzucchi, maybe I'll start with you. What made the results of this trial unlike anything seen previously?
Well, it's been one of the most frustrating aspects of diabetes care is that correcting what we all agree is a fundamental metabolic abnormality of this disease, which is hyperglycemia, has had no or little effect on cardiovascular outcomes, which is very perplexing. We can reduce retinopathy and nephropathy and probably neuropathy. But when you look at studies over many decades, it's been very difficult to demonstrate that lowering glucose with a specific strategy or any drug actually benefits the heart. So I think what Empareg outcome showed us is that you can improve cardiovascular outcomes, perhaps not through lowering glucose, but through using a glucose-lowering therapy. It was the first study that demonstrated a strong effect on cardiovascular mortality. And this was presented in September of 2015. And one of the more striking results from the Empareg outcome trial was that the SGLT2 inhibitor Empagliflozin was associated with a 38% reduction in cardiovascular mortality. I must say, when I saw these results, and I was on the steering committee for the trial, I almost fell out of my chair because it was very, very striking that a diabetes therapy that was not a hugely powerful glucose-lowering drug could have such a significant effect on obviously a very important outcome, which is cardiovascular death.
So this has really changed the expectations for outcome trials now going forward, hasn't it? Can you talk a little bit about sort of what we're looking at now in terms of cardiovascular trials and how they're designed?
Well, there's a panoply of these trials now underway, and I think we'll talk a little bit later on about the other SGLT2 inhibitor trials and some of the other drugs. So those have already taken off, and the design is very similar to Empareg outcome. What you do in these trials is you add a drug into the mix of medications that patients with type 2 diabetes have, and you compare that to a placebo. So it's not comparing one strategy versus another. It's comparing a glucose-lowering treatment approach using a single drug with other medications for diabetes versus not using that drug. So they're somewhat limited in what they can say. There are other trials that we may get to that actually compare the addition of two separate drugs to patients with type 2 diabetes. The second important point is that these studies are being conducted either in patients with established CVD or established CVD and patients who have lots of risk factors for CVD. So I think it's really important not to overinterpret these results, because there's always this temptation in our field, I think in most medical fields, to cut and paste what we learn from one group of patients to another. Primary prevention in terms of patients without prior history of CVD has not been demonstrated with any of these medications that we'll be addressing today.
Conclusion. In conclusion, among patients with type 2 diabetes who are high risk for cardiovascular events, the use of empagliflozin is associated with a slower progression of kidney disease than placebo when added to standard care. Empagliflozin is also associated with a significantly lower risk of clinically relevant renal events.